Welcome to this Peer Voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/JYG. This activity is supported through an independent educational grant from Merck & Company Incorporated, Rahway, New Jersey, USA.
Hello, I am Marc Imbert, Professor of Medicine at the Université Paris-Saclay and Director of the French Reference Center for Pulmonary Hypertension in Le Kremlin-Bicêtre, France. Welcome to this Peer Voice activity on pulmonary arterial hypertension. Pulmonary arterial hypertension, or PAH, is a rare, serious disease driven by pulmonary vascular remodeling, and it is often diagnosed late because of symptoms which are non-specific, with many patients presenting at advanced stages. Over the past 30 years, therapies targeting the endothelin, nitric oxide, and prostacyclin pathways have improved hemodynamics, exercise capacity, and extended survival from around 2 to 3 years to 5 to 7 years. But PAH remains incurable and disease progression continues, highlighting an important unmet need. In this first section of the activity, I will revisit PAH pathophysiology and how new therapies may help address the disease more directly. PAH is a severe pulmonary vascular disease which is driven by structural remodeling of the pulmonary vasculature. On the left-hand side, you have a normal vessel with a thin wall, and on the right-hand side, you have a vessel from a patient with PAH, which is extremely remodeled with a very resistant to flow vessel. So this structural remodeling can be improved somehow by vasodilatation approaches, either with prostacyclin, nitric oxide, or blocking the vasoconstrictive agent endothelin. What is important in the blood vessel and in the heart and in the systemic aspect of the patient is that you have multiple processes which occur and which will start in the lung and then have consequences on the right ventricle, and it will lead to disability and symptoms for the patients. So the processes in pulmonary arterial hypertension lie in the vessel, the pulmonary circulation. In that circulation, endothelial cell is dysfunctional, and they may lead to apoptosis. The smooth muscle cells in the vessels do proliferate, and they do have increased survival. There is also a smooth muscle-like mesenchymal phenotype and a pro-inflammatory microenvironment and a disturbed angiogenesis. All these dysfunctions will lead to remodeling with fixed obstruction of the pulmonary vessels, and it will be a strain on the right side of the heart. So it will lead to right ventricular dysfunction. For the patient, this will translate into exercise limitation, shortness of breath, fatigue, syncope, progressive right heart failure, and death if left untreated. So, as pulmonary vascular resistance rises, where does that chronic strain actually land? In terms of established therapies for PAH, we have 3 pathways which are historical: the nitric oxide pathway, the endothelin-1 pathway, the prostacyclin pathway. These pathways can be targeted, and they are complementary, and they can be targeted with combination of drugs targeting each of these pathways. What is really important is that there are benefits, but also limitations in the established pathways. The therapies improve symptoms. The therapies improve hemodynamics, but they do not fully reverse vascular remodeling. So in terms of benefits, you can mention that these treatments restore endothelial signaling balance. They do promote vasodilation. They do reduce pulmonary vascular resistance and right ventricular afterload. They do improve hemodynamics and functional capacity, but they have modest anti-proliferative effect. The pulmonary vascular remodeling remains. And the limitations which are still present despite these established therapies is that you do affect the vascular tone, but not the structure of the vessels. You do not reverse established remodeling. You have persistent proliferative and inflammatory signaling, and you have only a modest reduction in pulmonary vascular resistance. So all in all, you have ongoing disease progression and right ventricle dysfunction. So now we have new interventions for the treatment of pulmonary arterial hypertension. On top of established therapies, we can now target the TGF-β pathway. We have new agents, which are activin signaling inhibitors. And as compared to the established therapies, these activin signaling inhibitors have an action on pulmonary vascular remodeling. And that's truly important to consider these agents are innovative and developed in order to address something which was not addressed properly by the other drugs. The TGF-β superfamily in the pulmonary circulation is usually well balanced. There is an anti-proliferative pathway which signals through BMPR2 and which will limit proliferation in the pulmonary circulation. There is also a pro-proliferative pathway which signals through activin and activin receptor type 2, A and B, and this pathway leads to proliferation. In a normal, healthy pulmonary circulation, these two pathways are well balanced. However, in pulmonary arterial hypertension, the proliferation pathway is hyperactive, leading to overexpression and stimulation of the activin pathway. With ligand traps, we can block the activin and limit the activin-driven proliferation. So the agents which are ligand traps are novel therapies developed to limit remodeling in the pulmonary circulation. This is a new effect of a therapy given for PAH. Moving on from the established pathways, what do you know about the activin TGF-β pathway? Currently, the therapies targeting the activin TGF-β pathways are either recently approved or still in clinical development. For example, we have a ligand trap, which is sotatercept. It is an activin receptor type 2A ligand trap, which is given by subcutaneous route and which aims to restore signaling balance in the pulmonary circulation. In the clinical context, it has demonstrated improvement in hemodynamics and clinical outcomes, and it has been approved in the US and in the European Union. Another drug is LTP-001. It is a SMURF1 inhibitor which aims to restore the BMPR2 signaling. It is given by oral route, and it is currently in clinical development and evaluated in PH patients on background therapy with randomized control trials ongoing. So PH is not just a vasoconstrictive disease, but it is a structural proliferative vasculopathy where both endothelial signaling and vascular remodeling drive progression and right ventricular dysfunction. Understanding these complementary mechanisms is critical as it underpins how we approach treatment in clinical practice. And with that, I will hand over to Dr. McLaughlin, who will show how these concepts translate into treatment selection and optimal therapeutic strategies.
Hello, I'm Dr. Valerie McLaughlin, Professor of Medicine and Director of the Pulmonary Hypertension Program at the University of Michigan in Ann Arbor, Michigan. Thank you, Dr. Humbert, for that insightful overview of PAH pathophysiology and today's therapeutic landscape. Building on the pathways we just reviewed, in this section of the activity, I will focus on how to apply these insights into clinical practice, including how to select, sequence, and combine therapies for patients with PAH. We are so lucky to have so many therapies for PAH in the different categories that we currently have, including endothelin receptor antagonists, agents that affect the nitric oxide pathway, prostacyclin pathway agents, and the activin TGF-β pathway. And Dr. Humbert reviewed these pathways for you already, and these agents are used in clinical practice often as combination therapy for pulmonary hypertension with sequential escalation in patients who are not meeting our treatment goals. So I'd like to share a case with you of a patient that I saw recently diagnosed with pulmonary arterial hypertension. She's 48 and presented with a history of progressive dyspnea on exertion. Her only past medical history was hypothyroidism, and she didn't have any secondary causes of pulmonary hypertension. On the right, you can see her diagnostic workup. The important highlights are that she was functional class 3. Hall walk was suboptimal at 385. She had severe RV dysfunction and an estimated RVSP of 96 on her echocardiogram, and her NT-proBNP was 625. And of course, the next step to establish the diagnosis of pulmonary hypertension is a right heart catheterization. And here is her hemodynamic data. Her right atrial pressure was 8. Her mean pulmonary artery pressure was 64, so quite elevated. Her wedge was 8, which was normal. Her cardiac output was 3.85 with a cardiac index of 2.44, so a little low. Quite an elevated pulmonary vascular resistance of 11.2 Wood units, and she was given a vasodilator trial with inhaled nitric oxide, and her mean pulmonary artery pressure was essentially unchanged at 62. So she technically didn't calculate to high risk by any of the calculators based on her walk and NT-pro and functional class, but her hemodynamics show quite an elevated PVR. So let's review the treatment algorithm for pulmonary arterial hypertension that's from the 7th World Symposium on Pulmonary Hypertension. And of course, this treatment algorithm applies primarily to patients with idiopathic, heritable, drug and toxin-induced, and CTD-related PAH because those patients form the majority of the patients in the clinical trials. So the first step in the initial risk assessment is the patient high risk or not? And certainly for the high-risk patients, we use upfront triple combination therapy that includes a parenteral prostanoid. And in the footnotes of this algorithm, that is something that could be offered to patients who don't calculate to high risk, but have advanced pulmonary vascular disease with a high PVR or severe RV dysfunction. The majority of patients who are not high risk get combination therapy with an ERA and PDE5, and that's really just the first step. This treatment algorithm also emphasizes the importance of following patients up and risk stratifying after that first treatment choice. And then, of course, we use the 4-strata risk assessment to make the next treatment choice. So let's see what happened to our patient. So despite initial combination therapy, she has some limitations still and elevated biomarkers. So when she was seen a few months later on dual oral combination therapy with an ERA and PDE5, she had an improvement, but she still had functional class 2 symptoms. Her hall walk had actually improved quite substantially, but still not quite where we want it to be, especially given her age. Her NT-pro had also improved, which is great. Her echo demonstrated mild right ventricular enlargement and mild right ventricular dysfunction. So that's better than where it was. Her right ventricle has improved. As is sometimes the case, we could not estimate an RVSP in her because she had just minimal tricuspid regurgitation and the window was not good. She did have evidence of RV pressure overload. So when we put her information into the risk calculator, she comes out to intermediate low risk by the 4 strata, not quite where we want her to be. I, in this patient, repeated a right heart catheterization to get a sense of where she was, and her hemodynamics improved. We can see her right atrial pressure was 7, her mean pulmonary pressure was 32, so that's quite a bit better. Her cardiac output has gone up a bit to 4.61 with an index of 2.82, and her pulmonary vascular resistance is better at 4.8, still higher than we'd like it to be. So let's go through the second phase of the algorithm. So we have a patient that received initial therapy and we've reassessed them, and their risk is now assessed by the 4 strata. So low risk, we can kind of continue as is. High risk and intermediate high risk, they need escalation of therapy. And our patient fell into intermediate low risk, where there are several options, including an activin signaling inhibitor, oral or inhaled prostacyclin pathway agents, or switching PDE5 to SGC. In this case, based on her young age, her continued RV dysfunction, and her elevated PVR, we decided to treat her with an activin signaling inhibitor. We had also talked about the oral and inhaled prostacyclin pathway agents, although she had concerns about some of the side effects, including headaches. So we have some well-established treatment goals in pulmonary arterial hypertension, things that we have learned portend a better prognosis. Of course, we want the patient's symptoms to improve, and that's measured by functional class. We want increased exercise capacity, and we measure that by the 6-minute hall walk. And we've learned that normalization of biomarkers such as NT-proBNP is also a good prognostic indicator. We have many risk calculators, and we know that achieving a low risk profile improves the long-term outcomes. And we have many options to treat our patients. And of course, patients with very severe disease or rapid progression may need parenteral prostacyclin therapy. We have certainly come a long way in treating our patients with pulmonary arterial hypertension. We have many treatment options now, and we really need to think about the clinical response that patients have and what our goals should be. Early on, we just wanted to slow the progression of the disease and keep them from getting worse. But with the tools we have in our armamentarium now, we can improve our patients, we can improve the disease, and we can even get partial or even complete remission looking at hemodynamics and RV function. So I think we have the opportunity to be more aggressive with these goals, and hopefully that will improve long-term patient outcomes. Please answer this challenge question. Please answer this challenge question. So, I'd like to thank you for your attention. We hope this discussion has provided practical insights into the evolving management of PAH and how to apply these concepts in clinical practice.
This has been an activity published by Peer Voice.